It's a pleasure for me today to introduce our speaker this afternoon. Dr. Glenn Green is a professor of otolaryngology at the University of Michigan, and of course, practicing at the Mott Children's Hospital. He has many interests in medicine and the care of children, and has received many awards from his field and from others. And he's particularly interested in the care of children with syndromes and airway management, and we're going to hear some of that this afternoon. So thank you, Glenn, for agreeing to be our speaker today.
It's a great pleasure. So I'll start by sharing my screen at this point. And you should see my screen now. Okay.
Yeah,
So
we do now, Glenn.
Is this good?
We see it now.
Okay. So I'll be talking about newborn airway evaluation and treatment in trisomy 18. And this is our hospital right here. This is Mott Children's Hospital, and we're at the University of Michigan. Our stadiums are not full like this anymore. The airway in trisomy 18 is the most challenging airway that I deal with professionally. It's extremely complex, it's very severe and life-threatening, and it's multi-level, involving multiple different pieces and parts. It makes it very difficult and challenging, but also very rewarding to take care of these children. So I want to give a little bit of historic perspective on airway obstruction. This is the original description from Edwards in Lancet in 1960. He noted that during the first week of life, she had several cyanotic attacks. And you'll notice the child with the small mandible, the original description from 1960. This is another early description. Some dispute persists concerning 17 and 18. The chromosomal anomaly of Edwards syndrome probably involves number 18. So that at this time, they didn't even know which chromosome it was. And so this is a very early description, but I want to go and point out a couple things on this picture. Notice the very small chin. This is very common in trisomy 18. And also you'll note some retractions here in this picture. You can see the rib cage more than you should. So this child is retracting and has micronapnea, which are common features of airway obstruction in trisomy 18. This is Smith's, which was the Bible when I was a medical student for describing different syndromes. And this is from Smith's. 30% die within the first month, 50% by 2 months of age, 90% will die by 1 year of age. In Smith's, they said these children with trisomy 18, they may have apneic episodes. And so there's some partial appreciation and notation that the kids are having difficulty breathing, but the severity of this is not noted, and it doesn't appear that much of a workup was done at this time with these children. Here's another description of the physical abnormalities in children that have trisomy 13 and 18 syndromes. And if we look at the most important types that are noted, 90% die within the first year, and then cryptorchidism, low set, malformed ears. Way down the list here is apneic spells in infancy, 3 for trisomy 13 and only 1 for trisomy 18. So there's an underappreciation at this point of how severe the airway obstruction can be in trisomy 18. So again, survival broadly quoted, 95% die within the first few weeks of life from either cardiac failure or respiratory distress/apnea. And so this is where I've gotten heavily involved, is in the respiratory distress apnea side. So here is our personal outcomes at the University of Michigan. We have well over 65% 1 year survival. And my personal survival of children that I've taken care of It's well over 90%. So we're doing much better than historically. And so we say, okay, what is our evaluation and approach that we think is able to go and generate the survival, or what is our analysis that thinks that this is where we can end up? So airway obstruction in trisomy 18 is the most common cause of death in the first year of life. Children with trisomy 18, but without airway obstruction and without significant cardiac disease, can live long term. And so some of the children, when I looked historically at children that I had not been involved with at the University of Michigan, many of these children were assumed to die, but the children that didn't have apneic episodes or airway obstruction would frequently live for long periods of time in hospice or in the hospital. And then at that point, the family's like, oh, maybe we should go after the cardiac disease or do something else. If the airway obstruction and the cardiac disease are treated, long-term survival is expected. And I have dozens of patients at this point that are 5 years and older. So let's say, what is not normal? I want to go and take a step back and say, what is not normal for trisomy 18? Now, these are things that are frequently seen in trisomy 18, but they should not be viewed as something that's normal and not to intervene on. So stridor is an inspiratory sound, an inspiratory pitch. Stridor is a roncorous sound, a snoring sound. We know that these are not normal for regular neonates, and there are children with trisomy 18 that do not have stridor, nor do they have stridor. Retractions, we should not be able to see subcostal retractions in children that don't have airway obstruction. These are not parts of trisomy. These are not indelible parts of trisomy 18. And if we see these things, then it warrants evaluation and treatment in my mind. Obstructive apneic events should be less than 10 per hour. Greater than 10 per hour is not normal. And prolonged recurrent desaturations are not normal. So I just want to take a step back and say, when a patient has retractions and stridor, any use of narcotics and sedatives is perilous. When I reviewed the deaths that had occurred at the University of Michigan, this was not an infrequent occasion that even high-dose narcotics were given to some of the children that seemed to be having respiratory distress. In a child with airway obstruction, any use of narcotics or respiratory depressants of any type can be very problematic. When do we need to evaluate this? So when do we pursue evaluation of the airway in a child with trisomy 18? Any of the things that we noted previously warrant a workup. So any snoring or stridor that is heard in a child, if pauses in breathing or gasping breathing are noted, if we see any retractions that are going to occur, but also the airway should be evaluated if a child is going to undergo general anesthesia of any type. So if you've got a kid with trisomy 18 that is going to get general anesthesia for cardiac repair, for example, I think it's very worthwhile to have the pediatric otolaryngologist get involved up front for those children. So how do we evaluate these children? There are the easy, quick 3 types of things are observation and auscultation, the physical examination. Looking at, these should be done on any child with trisomy. So observation and auscultation, that's looking at the child, looking to see if there are retractions, looking to see if their position changes with retractions. So are the retractions worse in the supine or prone position? And any positionality, does the child do better when they're upright? O2 sat monitors, right now we're seeing more and more families using owlets or home O2 sat monitors. And so if we're seeing severe desaturations on the owlet, then that certainly warrants further evaluation. But any child that's in the hospital with trisomy 18 should have an O2 sat monitor. And if there are desaturations, then that warrants further work. A sleep study is something that I feel should be the workup of any child that has trisomy 18, even if no airway obstruction is noted. This gives us an idea how severe the airway obstruction is. Are there central apneas or obstructive apneas in situations that could otherwise be missed? In children that tend to be low tone, frequently we don't see the severity of the obstruction might not be noticed as apparently as a child that has normal neuromuscular tone and effort. And that's something that we see, that kids with trisomy 18 can be all over the place as far as the strength of their musculature and the vigorousness of the movements, particularly when they're early on. Some of the kids will be very, very flaccid, not a lot of motion, and some will be very vigorous. And it's difficult and requires expertise to identify airway obstruction within those two different groups. If there are abnormalities noted in the O2 sat monitor, observation or auscultation, or on a sleep study, then I recommend strongly considering two other steps forward. The first part of the evaluation is drug-induced sleep endoscopy. And the second is not just a regular CT scan of the airway, but an inspiratory and an expiratory CT of the airway. An inspiratory CT of the airway will miss problems with exhalation, which is when a lot of the severe tracheobronchomalacia is going to be evident on imaging. And so it's very important to have expiratory imaging as well as inspiratory imaging on the CT scan. So what are the results of sleep apnea in children that we looked at in all comers for trisomy 18? 48% had obstructive sleep apnea. So the good news is that half did not. Of the 48% with obstructive sleep apnea, 2 had moderate sleep apnea and 12 had severe obstructive sleep apnea. The mean apnea-hypopnea index was 31.8, ranging from 3.1 to 83.4, and normative data should be less than 1, to put this in perspective. Desaturations below 70% are particularly important, and that's a mark. But also the severity of desaturations can have an effect that is confounded and also has an effect on any concurrent cardiac disease. So for example, a child with cardiac disease may have low saturations, and obstructive sleep apnea or respiratory obstruction in general can exacerbate and lead to pulmonary hypertension earlier and more aggressively than in a child without concurrent respiratory obstruction. So it can make it difficult to delineate what is cardiac and what is obstructive. So the next part is airway management for these children. So we'll talk about, so if we have a child that has been identified with severe sleep apnea that we think should have some type of intervention, then this is the next step that we go to. So the first step is positioning. Positioning is, again, any child that is micrognathic, that has a small chin, will do worse when they are in the supine position. They'll do better. This is, just treat it like any kid that has Pierrot band sequence. So you have the child more upright, leaning forward, even place in a prone rather than a supine position to help out. These are particularly helpful for children that are having feeding difficulties. And so although many of these children do not have clefts, in fact, most do not have clefts of the palate, like a classic Pierrot band sequence, their small jaw and relative glossoptosis, or the tongue falling back in the throat, are exactly similar to many children with Paraband sequence and can be treated similarly. Intubation is another route for airway management that will bypass everything to the end of the endotracheal tube. If the airway is mainly due to the base of tongue and other things are okay, then distraction, osteogenesis, and we'll specifically talk about mandibular distraction later here. And then tracheostomy is definitively bypassing the upper airway. So the intubation for trisomy 18 is particularly difficult and should be viewed with caution. Neonatal intubation is difficult. The typical child is a grade 1 view, and the average child, the maximum grade is a 4 on this scale. The average child with trisomy 18 is 2.66 with a standard deviation of 0.77. We are right now putting together a paper on anesthetic management of children with trisomy 18, and I hope that we'll have this out for your view and for the website within the year. The Hollinger anterior commissure scope, which is particularly helpful for children that have micrognathia, was needed by an experienced pediatric otolaryngologist for intubation for half of children. So if a child with trisomy 18 is going to have general anesthesia, then bringing a pediatric otolaryngologist, excuse me for 1 second. So sorry, I'm a little distracted here. So the Hollinger anterior commissure scope with experienced pediatric otolaryngologic support was needed for intubation for half of children. So our recommendations on how to secure the airway for a child with trisomy 18. The first is to keep the children spontaneously ventilating. Don't take away their respiration. Second, confirm the ability to mask ventilate. Third, attempt direct laryngoscopy with a Hollinger laryngoscope up front with an endotracheal tube preloaded over a rigid versus flexible bronchoscope, and to have backup plans for intubation in place if these techniques are not working well. So the next thing that I'd like to go through is what is not normal after intubation. So intubation will resolve any difficulties with the base of tongue, with prolapse of the tongue, small mandible, palatal obstruction. These can all be significant issues for kids with trisomy 18. However, when this is done, if those are the only issues, then there should not be retractions. There should not be prolonged episodic desaturations. There should not be central apneic episodes. If these things are present in a child that has trisomy 18, then further workup and evaluation is needed, and mandibular distraction is not expect, and/or tracheostomy. Either of these would be expected to be curative for a child that is retracting despite having an endotracheal tube in place. And if they're having prolonged episodic desaturations despite having an endotracheal tube in place, then this also points to difficulty with an isolated tracheostomy or distraction being helpful. And so in these children, then in particular, tracheobronchomalacia and central sleep apnea tend to be the problems. And so the treatment, the most straightforward treatment for tracheobronchomalacia is positive pressure ventilation. Tracheobronchomalacia is, in my hands, is extremely common in kids with trisomy 18. This will respond to PEEP. In other words, just high pressure that's delivered through the endotracheal tube. And this can be, the level of PEEP can be determined through a PEEP titration study, where a flexible tube is passed through the endotracheal tube with pressures varying to determine what pressure is needed to hold the distal airway open during breathing. This is frequently done in the operating room, but it can also be done on the floor in the intensive care unit with people that are knowledgeable for this. Central sleep apnea does occur in children with trisomy 18, where there is inadequate respiratory drive. This requires a backup rate supported by a ventilator to treat, or elective non-treatment, where we'll just recognize that there will be desaturations due to central sleep apnea. So drug-induced sleep endoscopy is the procedure of choice for determining the sites of obstruction for children with trisomy 18. This is performed in the operating room with drug infusions to induce a sleep-like state. The child is brought down to the operating room. Different positions can be used, and we can see a variety of different things in children with trisomy 18. The things that are identified can then be directly addressed surgically or otherwise. So pharyngeal obstruction is probably the most common site of obstruction for children with trisomy 18. This can be base of tongue prolapse, palate prolapse, and micrognathia. The treatment options for these are tracheostomy, which will bypass the entire area, adenotonsillectomy, pharyngoplasty, and mandibular distraction can be helpful for these children. But identifying the source is very important beforehand. So this is sleep endoscopy demonstrating the palate against the posterior pharyngeal wall with near complete obstruction. Children with trisomy 18 tend to have a long, soft, redundant palate. This can be markedly reduced in size. Nearly a third can be readily removed in a child with trisomy 18 to improve respiration. I would also like to make a note that children with trisomy 18 are not expected to talk as much. They're not expected to talk at all, but some individuals will have some words. And so concern for hypernasality with resection of the palate relative to airway obstruction. My own bias is towards dealing with the airway obstruction with little expectation that speech would be affected. And if there was speech to be affected, then this could be dealt with secondarily at an older age. Over resection of the soft palate would not result in inability to generate speech, but would result in some pronunciation abnormalities, particularly hypernasality. Tongue base collapse. This is where the tongue is against the posterior pharyngeal wall on the second picture here. This is what is frequently seen in trisomy 18 when the mandible is small, there's not enough room, or there's glossoptosis and the tongue falls back into the throat and occludes the airway. Kids with trisomy 18 have the most severe type of tongue base collapse that I've seen of any syndrome. Here is a video of epiglottic prolapse with base of tongue, and you can see how the epiglottis is against the posterior pharyngeal wall, but in particular, you can see there's space between the base of tongue and the posterior pharyngeal wall, but the epiglottis is falling and closing off the airway. You can see the epiglottis, even though the tongue is not falling, the epiglottis is falling. Mandibular distraction can pull this whole area forward, but doing surgery specifically on the epiglottis or on the arytenoid, so a supraglottopexy is needed and helpful for many children with trisomy 18. And so here is a video of Laryngomalacia. where we see here we see the arytenoids ball valving in and including the larynx this way. So these are all things that we can see with trisomy 8. So mandibular distraction osteogenesis, or MDO, this is something that I first started performing in the mid-90s. It's become broadly used at most medical centers at present, particularly in the United States. This is very valuable for children that have obstruction at the level of the base of tongue. We've moved to younger and younger children with this and are now distracting children with hypognathia or small chin as initial treatment of choice for children that have severe desaturations in the supine position. Typically, it's going to be a child that has desaturation to the 70s. That's noted particularly in the supine position. A sleep study can be very helpful in getting more minute or second to second evaluation of the level of desaturations. Or you can go to the O2 sat monitor and change the averaging to typically in our NICU at least it's 8-second averaging, and we need to specifically change it to 2-second averaging to get an idea where the saturations, the depth of the desaturations. There are two types of ways of performing mandibular distraction. So that the general principle of mandibular distraction is a cut is made in the mandible, and as the mandible would normally heal that cut and form a callus, then the bone is moved apart before the full bone can be brought in. This allows bone to slowly fill in that gap over time. You can actually get quite a bit of distraction. They're on the range in a neonate, well over a centimeter of distraction can be obtained for children. The way of getting a rough idea of how much distraction is needed is to compare the alveolar ridge of the maxilla to the mandible, how much deficiency there is in this area. Particularly if the lower lip is falling below the maxillary alveolar ridge, kind of like this, that's a sign that the mandible is much too small and something should be done about mandibular size. So the original use of mandibular distraction was an external fixation. That's where the pins are placed through the skin and can be seen. So an incision is made below the mandible is dissected and is cut. The nerve is preserved with cutting of the mandible. The inferior alveolar nerve is kept intact, and then a distraction device is placed. You can see this is a guide to help place a distraction device. And then, so here you see the pins going through the skin and the external device placed. And here is the end result. When I first put one of these on at the University of Michigan, it made the newspaper. This is certainly, even at the time, this was not newspaper worthy, but this has become something that's pretty straightforward and should be available at any major medical center. Internal distraction has also been available for quite some time. With internal distraction, incisions are made again below the mandible, dissections performed, and instead of having the pins sticking through the skin, metal plates are put into the bone. Then the distraction arm is twisted, separate these two metal plates, and this is done through a separate incision. Advantages and disadvantages exist to both approaches. For one of the main disadvantages of external pins is the pins getting knocked with the child moving their head. Children with trisomy 18 tend to not be as vigorous with head motion, and so it tends to be much less of an issue than with other children. Post-operative care for the children is the same. Latency period is 24 to 48 hours. That's a time period where nothing's done with the distraction device. But after that 1 to 2 days, then we start using the screw to separate the two pieces of the mandible. This is not a painful process. You would think that this might be painful. In children, when we originally developed this, or were using this technique, we were doing this on children that were much older, that were tracheostomy dependent in order to have them be able to get rid of their tracheostomy. Frequently, kids with Paro band sequence. Usually, the children would ask for no pain medicine at all, but it might hurt for a couple seconds with the movement. We initially offered narcotics, but they were not used at all. So it's surprisingly not painful, despite the initial breaking of the mandible hurts, but the distraction part is not. And the distraction period, particularly in somebody that's profoundly hypopneic, lasts for a long period of time. After the mandible has been distracted, and typically we'll do a distraction that goes beyond, bring the mandible beyond the maxilla to result in class 3 occlusion, where the lower teeth are beyond the alveolar ridge of the maxilla. Then there's a consolidation period where the bone is allowed to grow in, so the device is left intact with no further spinning. And once the bone has grown in, this is verified by X-rays, typically 8 to 10 weeks of consolidation, and then it is removed. The internal implant requires a more complex removal than external implants, but either way, the device is removed after about 10 weeks. In kids with trisomy 18, it's going to be on the longer end of this, and X-rays can be very helpful for assuring that there's been good growth, a good bone ingrowth. As far as comparing the United States versus Europe, 4-row band sequence, this is 4-row band sequence in the United States, much more likely to do mandibular distraction osteogenesis as opposed to tongue lip adhesions or tracheostomies. So the same procedure can be done in children that are older with trisomy 18. It is not uncommon for children that have had distraction when they are younger, did not have the same level of mandibular growth that is seen in other children, and so the hypognathia becomes more prominent over time. If this is the case and obstructive sleep apnea develops, then repeat mandibular distraction or mandibular osteotomies, where the bone is cut and a metal plate is placed to hold the bone segments apart in one single operation rather than distraction, that can also be done. So if there are persisting desaturations or retractions after pharyngeal surgery or mandibular surgery, then repeat sleep endoscopy is indicated. And regardless of the salutary effect of surgery, then repeat sleep study at 3 months postoperatively is recommended to get an idea where things are. Persisting desaturation retractions after tracheostomy or intubation are signs of tracheobronchomalacia or central apneas. And we talked about tracheostomy ventilator use with PEEP titration for tracheobronchomalacia. There are new interventions that people are working on specifically for tracheobronchomalacia. We personally have been working on a 3D printed splint external scaffold that goes around the bronchus for severe tracheobronchomalacia. We had a child with trisomy 18 that was having severe desaturations and requiring, to the level that they required, multiple episodes of CPR despite intubation and high levels of PEEP. when the splints were placed, the child was able to be extubated and go home with no ventilatory support at all. And that child has is in a family that has had other children die from trisomy 18 with respiratory obstruction as well. So this was a major difference as a translocation trisomy 18. There are some new surgical techniques that are available at very few centers. Boston Children's is doing a posterior pexy that can be helpful. In the very severe cases, it is, especially if the left main stem bronchus is affected, it's less likely to be successful. Treatment of central sleep apneas, tracheostomy ventilator is going to, with the ventilator, is going to be primary intervention. When people hear about a tracheostomy and ventilator, they'll often think of grandpa in the intensive care unit about to die. This is an entirely different situation where the children are out with their family, tracheostomy and ventilator are put in a stroller. They're able to move around and play and interact with their family and be on a tracheostomy and ventilator. So this does not preclude development at all. In fact, allows the children to be much more mobile than they would otherwise be. So it might not be intuitive that that's the results that we get, but for children with tracheostomy and ventilators that have trisomy 18, these are kids that are very much part of their families and very much able to be interactive in a way that they wouldn't be if they, for example, were in the hospital. There are non-definitive interventions for airway obstruction. I think it's important to go and note that there are times that it might not be appropriate to do aggressive surgery or surgeries that have prolonged recovery periods. This particularly applies with the children that have unpalliable cardiac disease that cannot be treated surgically. Other severe systemic disease can also exist in some, can also have difficulties. And so I'd like to close, or disease that can't be palliated. So I'd like to close with some personal reflections. This is Faith Smith. They sent me this picture. They heard that I was giving this talk and sent me this picture of her before and after mandibular distraction. So I'm just going to go and point out that she's smiling in the postoperative picture, in addition to having a big chin. And so it is much more comfortable to be able to breathe. It allows you to be more active in ways that you otherwise wouldn't be able to, and really allows a child to be much more comfortable and much more interactive than they would be than without dealing with the respiratory obstruction. So it's just been a great pleasure for me to take care of families in the trisomy 18 community and to be interacting with them in a lot of very complex ways. And so I'm very appreciative of the chance to go and share some of my experience with you and open this up to any questions. Thank you.
Thank you so much, Glenn. And just, I think this is the third time I've heard you speak in the last few years, and I could see this is a lot different, and a lot of things are framed in a different way than you have in previous talks. Appreciate the added detail to some of the individual components of the airway evaluation. So thank you for that. I know that I was already texting Kelly. I know that that next week, as soon as this is online, I'm going to look at it again.
That's
so thanks. Great. So
we've been working really hard at trying to develop a more definitive algorithm on how to take care of these kids, and something that we can say, oh, here's really an approach that you can take that will be successful with these kids, and what kinds of things to look out for and how to intervene.
Well, your point about the the frequency and the severity of glossoptosis compared to other children we see with, let's say, more typical Pierre-Robin sequence really struck me, and just how much that might not be looked at until you started making us aware. And then I would review it with our own otolaryngologist, just a child we even saw recently, to look for that glossoptosis, because that seems obviously not straightforward, but it really is a defined anatomical reason for the airway issues. So appreciate that alertness to that.
And you're noticing that yourselves?
Well, what you made me aware of was making sure that our ENT docs, my colleagues here, would make sure they would focus on that particular, that we might not focus on because we don't tend to think of a Pierre-Robin-like glossoptosis occurring in trisomy 18. It wasn't something that was very prominent in the literature.
Yeah, it's not. And so just kind of like a background behind that is that when the mandible is not the size that it should be, it points to one of two problems. Either that the tongue itself is very small, or that the tongue is not pushing the mandible forward. So mandible growth is driven by the tongue pushing forward. And so if the tongue is not pushing it forward through a neurologic disease, then you'll have hypopnea from that. And so that is my own assumption as to what's going on when there's severe hypopnea, that it's probably driven by the tongue not having the strength that it should. And a lot of those kids will have glossoptosis. The easiest way to look for that is to have open the child's mouth and see if you see the dorsum of their tongue or their ventral tongue. And so if you open their mouth and their tongue's like this and falling back, and you're not seeing the dorsum of the tongue, that's abnormal for a neonate.
Yeah, that was something along the way that even more classical Robin sequence, whatever the syndrome it's seen in, that was something I had noticed, decades ago, but I don't tend to think about it in trisomy 18, even with a profound interest in Pierre Robin for the last 40 years. So thank you for that. So I want to make sure we definitely have time for other questions. I know there was one, Kelly, I don't seem to be able to pull up the area for the questions. I know that Laura had a question.
We have a question from Laura Elmer, Dr. Laura Elmer, and she just said I think she actually has two questions. So her first one was, she has a child, a 13-year-old with trisomy 18, repaired tetralogy with mixed obstructive and central sleep apnea. How would she reach out for a referral or a consultation? And then,
so that's particularly to me or to, so it's you consult pediatric otolaryngology at a tertiary care center and say, I want to have a sleep endoscopy performed by this child to sort out what's going on. I personally would be glad to see anyone or to help guide the process. Can I leave my email for people here, or is there a way to do that? I'll just say what it is. It's GEGreen, GEGREEN at med.umich.edu, GEGreen at med.umich.edu. What are the major centers in the USA for children with trisomy 18? Michigan, we're starting to see a fair number of these kids and get referrals for them. Nebraska, I think, is seeing a lot of kids with this. Boston Children's is being much more aggressive than they had been previously. With awareness of the survivability, most of the major hospitals are really changing the way that they are approaching trisomy 18. In fact, the other children's hospitals in the state have looked at what we've been doing here and want to go and start being more aggressive with their local children as well that have trisomy 18.
And I would add St. Louis University, Cardinal Glennon Children's Hospital to the list you just mentioned, Glenn, as being another center that is not only willing but actively sees patients. I don't know their otolaryngology team as much as I know the rest of the team. But as you pointed out, Omaha actually has a formal team.
Yeah, and Omaha has my former fellow. He's a very talented guy and very interested in taking care of trisomy 18. He knows the exact approach that we use here, and he's doing the same thing there and getting great results.
So Kelly, if you don't mind, I think there was another question. I don't seem to be able to pull up my Q&A or my chat. So if you could.
The questions are in the Q&A.
Yeah, so I can see it. So what would encourage the external pin versus internal plate with the mandibular distraction? So either one is fine, and so I'd go with the experience of the surgeon. The internal pins look better certainly than than having a big external device, but both work very well. And so personally, I don't. Distraction tends to be pretty big for kids with trisomy 18. Tends to be pretty profound micronathia. So maybe lean towards external versus internal, but both can be very appropriately used for these kids. Can you speak to how frequently children with trisomy 18 require adenoidectomy to improve mild to moderate obstructive sleep apnea? Okay, so mild to moderate obstructive sleep apnea in kids with trisomy 18, particularly older kids with trisomy 18, when the obstruction is palate or pharyngeal, then adenotonsillectomy, removal of the tonsils and adenoids, that's going to be first line for a normal child with mild to moderate obstructive sleep apnea. And so most places, that is going to be their default, is to go with the tonsillectomy and adenoidectomy. And so that's very appropriate. They for sure need to get a postoperative sleep study to make sure that was adequate. I think that adding sleep endoscopy beforehand, you can sort out how much of it is adenoid versus a redundant palate problem and address the palate at the same time as an adenoidectomy, hopefully be a little bit more effective and try to take care of the operation in a single setting rather than more. The other thing that I'd like to point out is that kids with trisomy 18 tend to have much more prolonged recovery periods than a typical child. So tonsillectomy and adenoidectomy would normally be an outpatient surgery. With trisomy 18 can easily be, I tell people to expect 1 to 2 weeks in the hospital. And so a much longer recovery period, but in the end, the kids end up doing well. Any thoughts on tongue tie and obstructive sleep apnea in children with trisomy 18? Yeah, this is a very important thing here. So when there's glossoptosis and the tongue, that's the tongue falling back. A lot of that is where you'll see the frenulum much more commonly. So you'll see the frenulum because there's glossoptosis. And if you cut the frenulum, that will actually allow the tongue to fall back farther. So frenulectomy is generally a really bad idea for trisomy 18 as a general rule. And generally we're doing getting rid of the frenulum for speech problems or swallowing problems. And it's just you're going to be more likely to notice a frenulum because of the glossoptosis, where you're looking at the ventral tongue with the tongue falling back in the throat. And it's actually the tongue tie that is holding the tongue forward and stopping it from fall back as much. And so you can markedly worsen obstructive sleep apnea and obstruction in a kid with trisomy 18 by performing a frenulectomy. That needs to be done very cautiously, if at all.
There was one last question, Dr. Green. On trisomy 13, do you recommend tonsil removal for sleep apnea?
Yeah, so trisomy 13, so I do not have nearly the experience with trisomy 13 that I have with trisomy 18. and just have even less than a handful of kids with trisomy 13 that I've taken care of. My experience is that the obstruction is not nearly as significant with trisomy 13, and that they can be treated much more analogously to a typical kid, or tonsillectomy and adenoidectomy would be initial treatment for a child that has sleep apnea. It's still worthwhile to get it, still important and worthwhile to get the 3-month postoperative sleep study.
So Glenn, let me ask a quick question, Kelly, before we sign off. We're still a minute away. So I've heard you talk about this before, Glenn, but do you recommend actually in the newborn period, before the baby leaves the NICU and other things have been evaluated, do you recommend a sleep study that early?
Yes.
Or, right, that's what I thought. Okay.
And you can get an idea if they're not able to get a formal sleep study, then turning the averaging down and looking at the level of the saturations over time can at least give you an idea where things are at. But a formal sleep study is really how you're going to differentiate central and obstructive, and where things are at, how bad the desaturations are, and give you an idea what kind of interventions you might or might not want to do.
Thank you.
I do want to point out, this is all evolving, and we're sorting things out and learning a lot from these kids and from the families. And so that this is still, we're still really early in aggressively treating children with trisomy 18 and sorting out what kind of benefits we can have and what works well for these kids, and how to sort them all out, and what kind of outcomes can we get. And so we've got kids that are getting a lot older. We don't know what that means. For example, that my experience with teenagers with trisomy 18 is limited, but the kids are getting older, and we're going to have that experience. And so that the need for repeat mandibular distraction, they weren't getting the mandibular distraction early. And so, what does a mandible do over time for these kids? You just have the first kids that are needing a repeat distraction now. And so it's that now, and the kids that have historically gotten a lot older, those are kids that have tended to be more vigorous kids, not have the same level of hyponapnia, not have some of the same problems that the more severe kids have. And so there's a lot still in this story for us medical professionals to learn.
Dr. Green, I want to really thank you for doing this, for presenting for us today. As always, we appreciate the information that you share with us and that we're allowed to share with our families. Thank you, Dr. Green.
It's been a pleasure.